deal with these situations. So today we have with us experts as panelists to guide us through some of these difficult scenarios. I, Dr. Pooja Tandon, along with Dr. Ashima, HOD Department of OB-GYN, extend a warm welcome to all the panelists. First of all, I would like to invite Dr. Mrs. Pramila Jindal, our worthy ex-HOD, an eminent practitioner with vast experience in OB-GYN, to help us out. So ma'am has been former professor in HOD, Gynae department. Next, I would like to invite Dr. Mrs. Manjeet Kaur Mohi, professor and head Obs and Gynae department, DMC Patiala.
बाहर से डॉक्टर मंजीत मोही को ढूंढ कर लाओ.
I extend a warm welcome to Dr. Sita Thakur, professor and head department of OB-GYN, Dr. Rajendra Prasad, Government Medical College, Tanda. Next, I would like to invite our savior, Dr. Kamal Arora, who keeps on helping us when we have to deal with high-risk pregnancy, preterm babies, and babies with birth defects. Welcome you, sir.
I think Dr. Manjeet Mohi is outside. We've gone to fetch her. In the meantime, we'll start with the panel questions. And again, excuse me for the voice. So Dr. Pooja will start with the first case.
So our first case scenario is a 35 years old, unbooked primary gravida who presented in OPD at 19 weeks with ultrasound suggestive of bilateral choroid plexus cysts more than 2 centimeters. Her routine antenatal tests, including NBNT scan and first trimester screening, were not done. So I would like to ask Dr. Sita, ma'am, which test would you order? So we have
choroid plexus cyst.
choroid plexus cyst.
Choroid plexus cyst normally it can be present in 1 to 2% of the normal pregnancies also, but sometimes it is associated with some aneuploidies also. So it is basically associated with the aneuploidy 13, and normally if it is associated, if it is a high risk pregnancy with the previous history of some anomalies or age of the lady more than 35 or any NT-scan or the NT-scan or the first trimester scan, something abnormal, then only we require to do something about it. Otherwise, it's a normal thing, and by the we just follow it, and after around 7 months or something, it usually goes. If it is high risk, in a high risk patient, we need to do the various tests like.
So the high risk here is 35 years, and she has a size of 2 centimeters. So these two factors.
We need to do the various scanning tests as well as amniocentesis in these patients. Or POGs, ma'am?
Sorry? 19 weeks, ma'am.
We need to do the amniocentesis and then karyotyping or the chromosomal microarray.
Yes.
Right. So 2 centimeter cyst, please note, is a high risk factor. 35 years is a high risk factor.
And we also need to do the targeted ultrasound to rule out other CNS anomalies or the cardiac anomalies or maybe some renal anomalies.
Had we detected this earlier, maybe at 18 weeks, so we would have also liked to go in for quadruple and NIPT. But since it is at 19 weeks, we won't have time further to get diagnostic testing done. So here straight away we would go for amniocentesis and karyotyping and microarray.
I'd just like to add one thing, that mostly the patients that come to us in our OPD with small choroid plexuses, maybe 2 millimeter, 4 millimeter, and they're really worried. And sometimes patients come even for termination. So it is very important to know that this is not an indication for termination. Very, very clear. It is the size is more than 1 centimeter, and another problems are there. Only then think of it.
Who Dr. Sita had already talked about.
Yeah. So choroid plexus cysts are associated with which chromosomal abnormality? Most common it is trisomy 18. It is 30 to 50% of the times. So if all the above tests are normal, as said, that we should get a serial ultrasound done, 90% will resolve by 28 weeks. Now if the patient asks for serial ultrasound for monitoring of the cyst, is it useful?
No.
Dr. Manjeet to answer this.
No. No, it is not useful because it is automatically going to, because it is not going to change our management.
Exactly.
It is going to resolve.
So question for the neonatologist. What has been your experience and what is the long-term prognosis?
When we get an antenatal consult from the gynecologist or obstetrician for that there is a cyst, we usually see that there is a bilateral or not, first thing. Second thing, we definitely see the size as already discussed. We see the associated abnormalities. Any abnormal screening tests like quadruple or any test if it is there, then only we go ahead with a termination, everything we already discussed.
Mother says, if you say it is okay, mother says what will be the long-term prognosis, what are you going to guide her?
The long-term prognosis is very good with the single choroid plexuses smaller than 1 centimeter. And agar bilateral bhi hai and they are not associated with other abnormalities, then also it is very good. And they are not the true cysts, they are just the infoldings of the neuroepithelium. That's it. It's not a true cyst.
So we also have questions for the audience.
I would just say this is a soft marker. If it is associated with other markers, then only with it. So we have many soft markers. This is one of the soft markers for the downs of the trisomy.
Right. So isolated CP cyst, no long-term neurological development. So it is a normal finding.
So I would like some of the residents to answer this. Which size of choroid plexus cyst is considered significant? Anyone? More than 1 centimeter. And what is the incidence of choroid plexus cyst?
It's already discussed. You were not listening to the panelists.
You have to listen carefully. We'll be asking you questions. So it occurs in 1 to 2% of normal fetuses. And what is the incidence of isolated CPC?
It's very, very low.
Very low. It is 0.2%. So next we have a 30 years female presenting as DREVDA 3 abortion 2 at 19 weeks with ultrasound showing cerebral lateral ventricular dilatation of 10 millimeters. Her routine antenatal tests including NBNT scan and first trimester screening are normal. So I would request Dr. Pramila Jindal to answer our next question. What is our diagnosis?
Excuse me.
So it is?
So our diagnosis is ventricular.
Sorry.
Sorry. Ventriculomegaly.
Yes, ma'am.
Mild ventriculomegaly.
Ma'am, please elaborate on the differences in the size of mild and severe ventriculomegaly.
Yes. Less 10 to 15 we take it as mild, and more than 15 mm is taken as the severe.
Yes. So what is the difference between ventriculomegaly and hydrocephalus?
Ventriculomegaly is just the enlargement of the lateral ventricles, but there is the intracerebral pressure is normal. Whereas when there is a hydrocephalus, production of the CSF is more and the pressure is more, and that in a severe case that can also cause the thinning.
It can cause the enlargement of the head.
Yes.
So basically ventriculomegaly could be due to any cause. One cause could be a hydrocephalus where CSF is more. So ventriculomegaly we have a lot of causes. Do we have a slide?
No. So what additional tests are required in this case?
So in this case again it could be associated with the other chromosomal abnormalities. So we need to rule out, no doubt, in this case first trimester screening is normal, but still there are so many soft markers which come up in the second scan, level 2 scan. So we need to rule out and take all the modalities into consideration to rule out all the other chromosomal abnormalities. So for that matter you can have the fetal MRI also, amniocentesis for the microarray and karyotyping for the chromosomal abnormalities, fetal echo that will associated cardiac abnormalities that will be taken out, and torch profile because this could be as a sequelae to the infection, especially the CMV. So we need to go for the torch profile also.
The patient says she cannot afford a fetal MRI. What do you think? Can we skip this test, fetal MRI?
Yes, we can skip in a mild cases, and because that is going to give us the thinning of the brain tissue only. So in mild cases thinning is less, as in this case our ventriculomegaly is just 10 mm. So in this case, in case she cannot afford it, we can miss it.
So fetal MRI can be skipped, rest tests should be done.
So what is the significance of performing amniocentesis in these patients?
So because this is associated with this could be isolated. If isolated, carries less of the significance, but if associated with the other trisomies like 8, 9, 13, 15, 18 and 21, So definitely this carries more.
So we have to advise the patient to undergo amniocentesis because the incidence of having some aneuploidy or chromosomal abnormality could be as high as 14.2%. So if all the tests come out to be normal, then what should we do?
So if everything, that means it is isolated, so we need not to worry much. Only thing is we can keep a check on the enlargement of the ventricles.
So that means serial ultrasounds
serial
should be done.
ultrasounds we should do it and manage the till term, and then we deliver this baby. But definitely this delivery has to be in a tertiary care center where all the other multidisciplinary approaches are available.
If the patient requests for an MTP, then how would you counsel her?
See, isolated does not demand the MTP, and especially we got it diagnosed at 19 weeks. We have a very less time for the chromosomal abnormality ruling out also.
So she says, I don't want to go ahead with the test, do a MTP.
Not. Because first trimester scan is normal, which is quite good sensitivity and specificity. So we should counsel her, and I think law also doesn't allow us to.
Yes, you should not counsel her for termination. Let her continue, do the counseling, rest it to the patient.
So we just have to make sure that there are no other neurological abnormalities, and then we'll advise her to continue with her pregnancy. So the patient is now followed on serial ultrasound till term, and the ultrasound done at 38 weeks now shows 15 mm dilatation. So
now
what will be the
preferred? She's gone into severe case. You started with mild, now it is severe. Now you have to deliver.
So because now she has come to the 15, ideally she should be delivered by a cesarean section with the pediatric surgeon available, so that we can actually do the shunting at the as soon as the baby is delivered. But in case she insists upon the vaginal delivery, then we have to do the centesis. And then the prognosis of the baby is going to be really compromised.
Right. The carry home message is you can deliver her vaginally if she knows about the prognosis, but if she's ready for a surgery, do a cesarean section followed by a shunt surgery.
I slightly differ on this part, that as a neonatologist, that we should counsel for MTP or not. The issue is that we have seen 3 cases delivered here which were associated with corpus callosum agenesis, which was partial. And now the patient has long-term prognosis are not very good with that. Maybe it's a mild deficits.
So that partial corpus callosum agenesis, when did you diagnose that?
That was picked up at 23 weeks
So
with a fetal MRI. So skipping that fetal MRI would be it would be difficult to say that if we skip this fetal MRI and we are not able to diagnose on ultrasound, a partial agenesis of corpus callosum could not be picked up. And that is okay with the radiologist. But a fetal MRI picked up that, and they were counseled that may have that prognosis poor. Then they had to continue because it was 24 weeks. But
so just a minute. Question to Dr. Manjeet. She comes to Patiala Rajendra Medical College at 24 weeks with the request of MTP.
Definitely, I'll ask her, like in this particular patient, if there is a corpus callosum agenesis and there is a ventriculomegaly, I know the prognosis is going to be bad. I'll ask her to go to court, get an order, and then there is a board is there. And
so why I said so, because it has been said that Patiala and PGI, they have the authority to do
and
MTP at 24 weeks.
Yes, we are doing it.
So you also need to take permission,
or
you do
from
it?
Court. Patient will go to court, bring the court orders. There is already a board is formed. Board will sit and again repeat MRI or fetal MRI will be done, and then will be decided.
So MTPs are being done at PGI and Patiala at 24 weeks after permission. So this is for the information to the house.
This is a soft marker also for ventricular dilation, is also soft marker, but not as soft as the choroid plexus is. So you need to be very careful whenever we see the atrial dilation, and specifically if you are seeing the dangling choroid, which is actually like a 3 mm away from the lateral wall of the lateral ventricle. So if it is away by 3 mm away, then means again it is a atrial dilatation is there, because we measure at the level of the atria. So be very careful when you counsel that you have to continue pregnancy, because now if this patient is coming with a 10, now she's coming 15, she'll say you said that it is 15. So how do we go about that now? So you have to tell everything.
So good counseling about the disease has to be done to the patient.
Ma'am, I would like to ask why Patiala and PGI have the
No, we don't have
right
authority in
to do
DMC.
at 24 weeks, not others.
Yeah, we were said that only government institutes can do, not a private practice.
We are
So, ma'am,
we can't
are
see
you
from
doing
here
it,
to
ma'am?
Tanda.
Ma'am, are you doing these terminations?
So let's have the view. What are you doing at Tanda? Are you doing MTPs at 24 weeks? 20. Right. Government medical colleges.
Government medical colleges, ma'am.
Ma'am, one thing more. Does it make a difference if it is unilateral, ventriculomegaly and bilateral? Does it make a difference in your context?
You tell.
No, because I am telling you because because the question was the bilateral.
We are going to ask questions. We are going to answer.
Bilateral dilation, because again, if it is both sides, then it is actually leading to the colpocephaly, which we say as corpus callosum agensis. That's a hint towards the corpus callosum
Yeah,
agensis.
so the bilateral would be more disastrous.
More disastrous.
Right.
So we come to the next case scenario. Is a 30 years old primary gravida at 8 weeks. She comes to OPD with beta thalassemia trait. Her husband is also beta thalassemia trait. So how will we counsel them? Dr. Mrs. Sita Thakur.
beta thalassemia in the
Trait in both the husband and wife.
beta thalassemia is basically a single gene defect, and the defect is in the beta globin chain on the chromosome number 11. So it can be since she is a beta trait. So if the husband is not, it's a normal or husband is also trait. So 25% of those babies born to her will be major, thalassemia beta major, and 50% will be trait, and the 25% may be normal. So this 25% which will be a major will be a problem for the patient. So we have to screen the fetus also for the transmission of this trait or for major. So we have to do the chorionic. Initially we get the hemogram done, and by that only we suspected hemogram and the chromatography and hemoglobin electrophoresis, and to know whether they.
But electrophoresis is already done. The parents are already diagnosed.
This is already. She's a known case, so we'll just do the chorionic biopsy of the fetus.
Before that. Because in chorionic villus sampling, you have to know what the parents' mutations
so we have to do
carrying.
the parents' mutation, which mutation, because we have beta thalassemia, around 150 mutations, which can cause beta thalassemia. It can be deletion of the chromosome, or it may be translocation also is involved in this. So it can be diagnosed by electrophoresis, but for the baby, we require to do the maternal and the paternal chromosome mutation pattern, and then for that pattern, we'll test the baby chromosome analysis.
So this is the question. Whenever you get both the parents, please do the gene mutation test and then refer her further for CVS.
Because which gene is getting the mutation out of these 150, we have to know to find out the chromosome, of the chorionis villus.
Right, there are almost 150 gene mutations seen. So if you know beforehand, only then you can test that for CVS.
So if she gets the test done, however, she asks if there is anything that can be done to avoid the risk of thalassemia major completely. So she doesn't want to take that 25% chance as well.
Okay. She comes to you preconceptionally. She says her fiancé is beta thalassemia. She's beta thalassemia.
Okay.
How
she's not before conception.
Yes.
Before conception, then we can do.
Counseling. What will you counsel?
We can do the counseling regarding how much percentage chance she has got of the baby having thalassemia major.
So how will she get rid of that?
Then we can do the choosing of the, pre-gestational diagnosis of the PGT. PGT we can do pre-gestational diagnosis of the thalassemia, and then which fetus is not having that, which embryo is not having that we can do the IVF with that baby.
So you do the IVF, do the biopsy of the embryo, and before transplanting you make sure that the baby is fine.
This is the definitely if they want to have their own child. But in case there is, because this involves a lot of uncertainty and the financial aspects. The better if her financial status is also compromised, you can ask the lady for the embryo donation also, so that in the next future generation, all the traits will be corrected. So let her have the donor egg and donor sperm and the embryo donation, that will be treated everything.
So now she brings her sister who is a thalassemia major, her husband being normal. So what will be the preconceptional counseling for the sister?
Thalassemia major usually don't go, previously they never used to go till the pregnancy state, mother to the age to till pregnancy, but now with the advent of the blood transfusion, regular blood transfusion, and with the chelating agents what we give for the hemosiderin, and so they are going now up to the age of the conception. So in that case, if she is thalassemia major, then we have to know, because she is at risk for cardiac problem, she is risk for renal problem, she is risk for other, so we have to do the hemogram of the patient, and so that she is not anemic, she is renal, this thing is okay, liver is okay, because she may suffer CCF for complication during pregnancy. So pregnancy complication, to prevent pregnancy complication, her status should be okay.
So she has
So
to
then
be
she can have the
evaluated
pregnancy.
fully.
She can have the pregnancy, but during pregnancy we have to continue the transfusion, we are transferred, but not the chelating agents. Chelating agents, desphoric, pyroxamine, we are don't give,
Right.
because it is a.
And we are happy to announce Dr. Kamal's department has 2 thalassemia majors who delivered with us, and we had to monitor them fully, and those were the, if Dr. Kamal would like to comment on that.
That was Dr. Shrutis, I would say, and Dr.
Okay, that is what I said, your
Sopti ma'am's-
department.
Yeah, that's it. And that was a true combined effort, and now both they are staff nurses here, and they both have delivered, and they are working in the thalassemia only. So both the babies are normal, doing really well, and they are completed now 1.5 years almost. So that was the one part which we wanted all to be encouraged for the thalassemia.
Thank you. So question for the house, which is the simplest test to suspect thalassemia?
She's a poor patient, she comes to you, I don't want to afford much, which test you'll order?
CBC. So what should we look for? HB, MCV, RBC count, and red cell distribution, red cell width distribution. And which is the specific test for thalassemia? HPLC.
So,
next.
Dr. Kamal agrees with this?
Surely, ma'am, definitely.
Okay.
So case scenario 4, 24 years old female presented in OPD as gravida 3 para 1 living 1 abortion 1 at 18 weeks and 2 days of pregnancy with a previous vaginal delivery with a fetal omphalocele of almost 5 centimeters on level 2 scan. No other associated anomalies were present. Her routine antenatal tests were normal. Her first trimester screening and NBNT scan was normal.
She says, I want to continue pregnancy. Oh, she requests for MTP.
Actually, if you want to learn omphalocele basically you have to learn how it has come. Caudal, cranial and lateral folds, they are folded at about 11 weeks. So whatever is herniated outside the umbilical, that goes back. But something goes wrong that about 11 plus 6, it doesn't go back inside. So it persists over there. So cranial and caudal, they are close. Sometimes they can be associated even with that defect also, cranial, caudal also. So which is a very challenging part. So if it is an only true omphalocele, means only central
Yeah, it is a
closure,
central
there is
omphalocele.
no center closure is not there, and it is about 5 centimeter. So like it is a giant defect as per as the literature says. So it means that the possibility that as we say that the umbilical cord will be sitting on it, and gut, stomach, maybe liver, may be coming out of through this particular part defect and coming outside. Only thing is that suppose this patient comes to me and asks me for MTP, what is her age? I don't remember.
28.
Young patient.
She's young.
She's 24.
So
She has a
is
very
young and she is the third gravida with previous 1 abortion, 1 living issue. So my and her previous NBNT scan, they are also normal. So possibility of chromosomal anomaly is comparatively ruled out. I cannot exclude it, but
Yes.
definitely it has been comparatively reduced. So I can counsel both ways, because omphalocele, carrying a baby of omphalocele till term and evaluating a baby of omphalocele is again a challenge. We have to see completely about her cerebral, brain part, cardiac part, kidney part and genitals. Completely we have to evaluate them well. If everything is normal, still some possibility of chromosomal anomaly will be there.
So that means a targeted
So
scan
targeted scan plus
something-
amniocentesis
amniocentesis
has to be done. So at least I will be 100% sure that the baby she is carrying is not chromosomally abnormal. Because it will be really crime at my part if I allow her to go and baby is chromosomally abnormal.
This
So
5
this
centimeters is what? do you think it is a small or
It
a
is a
large?
giant. I've told you it is a giant, as per literature is saying.
So we need to carry out certain tests to rule out the anomalies, aneuploidies, so amniocentesis, MRI,
Everything.
fetal echo. So what do we do the amniocentesis for?
Definitely. Chromosomal anomaly. 18 is very common in
Right.
this.
So
50%
please
of
note
the
all
times.
the tests to be done, evaluated very carefully, the echo, MRI, amnio for microarray.
And fetal echo is done for ruling out
She's already answered.
if there is a major cardiovascular abnormality associated with Omphalocele, then the mortality is almost 100%. So we have to really rule out the cardiac malformations as well. And if the patient comes out to be normal, then how will we monitor the patient?
If everything is normal, scan is normal, typing is absolutely normal, then she can continue with the pregnancy as a normal pregnancy is going on. Only thing is that you will be more concerned about
serial
gut may go back, but it is not possible. She'll be taken till term, evaluating all another her means parameters. So once she reaches that term, now there is always a dilemma whether to deliver vaginally or
Now
by
we are
the
talking
cesarean
of the
section.
giant Omphalocele.
Giant Omphalocele.
And she has a previous vaginal delivery.
Previous vaginal delivery, because I have searched the literature, so they have seen that there is no difference whether you deliver by vaginally or by doing a cesarean section. So there is no difference. It is the person who is performing, definitely it will be done in a tertiary care hospital where facilities are, pediatrician and everybody is available, and a senior obstetrician is delivering the baby, vaginally, even by the cesarean section. Everything remains the same. Because the contents may be gut, may be liver, we can injure anything while if we are not careful.
So
Once the baby is delivered, baby, only thing is that at that time neonatologist may not be available. It should not be covered by the wet thing. Very important. हमारा कोशिश होता है उसको ढक दो फटाफट. So that should not be done. Call the pediatrician. He will put a NG, deflate it, and then surgery will be planned according to the other.
Yeah, because vaginal delivery can happen anytime. Neonatologist has to be there. So you can prefer a cesarean section so that the baby handling is little less and there's no rupture of the contents.
And postnatal surgery would be required, and so it needs a multidisciplinary approach and an institutional delivery. So question for the house, what is the most important prognostic factor in Omphalocele? Size?
Size and
Presence
And
of
presence
other
associated
associated
anomaly.
anomalies. So if there are no anomalies, then we can let the patient continue with the pregnancy. So sir, what has been your experience?
With the Omphalocele, the major thing that already discussed is associated other abnormalities. We have 8 patients on our follow-up. 7 didn't have, but the first baby was a macrosomic and turned out to be Becker-Whitman syndrome. The baby had a hypoglycemia again, then a hyperglycemia. So now the baby is still on follow-up, mild MR, but otherwise baby is doing well. So Omphalocele, as you said, less than 5 and more than 5. But if it is less than 5, it has more associated abnormalities. More than 5 has less associated abnormalities. So prognosis with the more than 5 centimeters is actually better with the major ones because the associated abnormalities are less. So that's what our experience is, but they do very well in their long-term outcomes if their associated abnormalities are not there.
So rule out other anomalies, otherwise babies do fairly well.
So next scenario is a 32 years old primary gravida who presented in the OPD at 23 weeks of gestation with polyhydramnios with double bubble signs suggestive of duodenal atresia. The level 2 scan otherwise was normal, routine antenatal tests were normal, FTS was not done, NT scan not done, second trimester screen quad breast not done. How will you counsel the patient? So what will be the further line of management?
Go back to the question. So here what we are highlighting is level 2 normal, and at 23 weeks she comes back to him. Question 2? Question 2?
Dr. Jindal, ma'am, please.
Dr.
So there is a congenital malformation, no doubt that second trimester screening is not done. It is not done. That means still there is a possibility, could be a chromosomal abnormality. But in this case, I mean, because GIT and abnormalities are associated with the diabetes, uncontrolled diabetes also. So we must rule out the status of the diabetic status. And if that is normal, then we should go for the amniocentesis to rule out the chromosomal abnormalities.
To be fast.
So we have to go
yes.
through OGTT, fetal
Yes.
echo, amniocentesis to rule out trisomy 21, and serial ultrasounds at 2 to 3 weeks.
Associated abnormalities.
So patient asked there is appearance of polyamnios and duodenal atresia at 24 weeks. Why?
Because in early the respiration is not that effective, but by this time the respiration is too good for the baby, and this baby also inspires and takes out the fluid. So there is a hyperplasia of the lung, and now that is why there is a antenatal treatment for this.
Yes.
That you occlude the trachea so that the hypoplasia of the lung is not there.
Right. Right.
So that is the basis for the antenatal treatment of the this also, because this will ultimately, that is going to compress the chest, so that is going to cause the lung hypoplasia. So that will prevent it.
So please note, these anomalies can come up later, so you have to counsel the patient accordingly. And now we have the in utero treatment also at some places. So we'll just hurriedly go through another case and then wrap it off.
So now is a patient 30 years old, gravida 2, para 1, living 1, comes to OPD at 18 weeks with ultrasound suggestive of congenital diaphragmatic hernia. So what are the prognostic factors
So
when we have a diagnostic?
Diaphragmatic hernia also, again, it's a GIT problem, and around 15 to 25% have the chromosomal anomaly, genetic anomalies also. And it is also associated with, because there is the opening in the diaphragm, so the liver or the intestine may go into the thorax, and which leads to the hypoplasia of the lungs and all problem. Because of that, hypoplasia is the main problem in this. The prognostic factor will be additional associated chromosomal anomalies or associated other anomalies of the cardiac or the chest problem. Prognostic factor, lung to head ratio, if it is more than 1.35, it's a good prognostic sign, and less than 0.6 is a bad prognostic sign. Second is on MRI, the lung volume, and it is better than the lung to head ratio. So we calculate on the right side or the left side of the lung, this diaphragm, lung volume by MRI, and then that will give us the prognosis. And another prognosis is the liver herniation. Liver herniation is in fact worse prognosis than the other two things, because liver will go to the lungs and hypoplasia of the lung will be there.
So please note, whenever you see a CDH, look at the liver, look at the lung volume before counseling the patient.
This is a nightmare for us. The congenital diaphragmatic hernia, the prognosis is not very good, because the degree of hypoplasia, lung hypoplasia, is a major diagnostic thing. Whenever the baby comes to us, if the baby presents too early with a respiratory distress, it means the baby is going to not survive actually. If the baby is being referred from another center coming after 2 days or maybe 36 hours and the baby is doing well, it means the lung hypoplasia is not there. So the prognosis actually depends upon the time of presentation. If it is the fetus is presenting less than 24 weeks with the CDH, it means the prognosis is going to be bad, because the lung hypoplasia has to happen. Even if the associated abnormalities are there or not, but the degree of hypoplasia is the major thing which will happen, because if the liver is herniating, it's a right-sided diaphragmatic hernia, it will be a problem for us. And the prognosis is only, even when we worked in AIMS and PGI, the prognosis is only 5 to 10%, not more than 10% in any of the best centers. Even if we do this surgeries like the plug and the exit procedures, this is ex-uterine interpartum treatment to grow the lung, or we plug the lung until it grows in the fetal part also. Still, the fluid inside the lung doesn't allow that much to grow, because the compression from the outside is too much. So lung head ratio is very important. We don't need a fetal MRIs in this case.
Yeah. So in utero treatment available, but high mortality.
So what is the preferred mode of delivery?
One thing is more important in these cases, because in these cases, these babies, they will have ultimately pulmonary hypertension. Even if they survive by the pneumologist, they will have a shorter life.
Yes,
because the arteries they undergo the problem.
I'll just add. Ma'am has added actually very right process. This is a primary hypertension, not a secondary hypertension, because the pulmonary vasculature is not well developed. Thank you for adding, ma'am.
So ma'am, what is the mode of delivery which is preferred?
We always prefer vaginal, because
Prognosis
prognosis
is not good.
is
Why
bad.
to give a uterine scar
Yeah,
to this patient?
cesarean section at a tertiary center.
So question for the house, which side is more common, congenital diaphragmatic hernia?
Left or right?
left side, because
75%.
on the right side there is a liver to protect. Liver नहीं आने देता उसके ऊपर. So it's a left side which is most common.
So which other anomalies are associated?
If you have a right-sided diaphragmatic hernia, then group B streptococcus has to be ruled out with these babies. It is sepsis which is going on inside.
So which other anomalies are associated? Okay, one pulmonary hyperplasia will be there. Any other? So they can be gut malrotation, neural tube defects, omphalocele, cardiac defects.
And left is comparatively easy to diagnose than the left, because there is an echogenicity is different. Liver has got same echogenicity as compared to the lung. So
Absolutely.
sometimes they miss it.
Right. So thank you, panelists. We are running short of time, so we'll just stop here. And
Thank you, Ashima, for inviting us and giving us an incentive to read about it.
Thank you, ma'am. Thank you so much.
We have been asking the gynae people to do this again and again because echogenic foci, soft markers, pylectasis, renal dilatation, kitna hai, kisko follow karna, kisko nahi karna, single kidney. I think these are.
if you
Yeah,
give us,
that's what
if
ma'am.
you
We
give
had
us
some
30
more questions.
If you give us more minutes, we can do that.
Because once you refer these cases,
So commonly we
pylectasis,
also have.
want it?
Yeah, we'll
So
discuss short.
so
in
we'll
short
just
session.
finish.
patient asks us कि भाई इसकी कोई दवाई देनी है आपने means
So we commonly get this kind of a scenario that anomaly scan shows renal pelvis dilatation of 4 to 6 mm. No other gross congenital anomalies. Routine tests are normal.
आप ही करा दो.
So the best possible diagnosis is renal pylectasia, and the significant dilatation in second and third trimester, it is mild and moderate and severe.
You have to learn these values.
Yeah. So 90% of them improve and never become hydronephrosis. So we have to learn the etiologies, utropelvic junction obstruction, vesico-uteric reflux, the fate, generally it improves. Then we also come across so many times intracardiac echogenic focus and no other finding. So what should be done?
Quick.
Nothing.
So the significance of isolated intracardiac echogenic focus, we even need not get a fetal echo done. It is simply discrete structure near papillary muscles and chordae tendineae that move in synchrony with the intraventricular valves. Although sometimes it is associated with other soft markers, and at that time we need to rule out Down syndrome.
This is a softest marker.
This is the softest marker. The other markers will
Are
be
still soft. But
Yeah.
lateral ventricle is not the soft one.
right. So we have to look for other markers. If those are present, then we need to do further testing. Thank you.
Earlier you find a soft marker and there are two soft markers, then you have to go for another test and the counseling should be done. Only one soft marker doesn't carry any significance. That's the bottom line.
Thank you.
Thank you, panelists.
It was a very informative session. I would like to thank all to help us dwell deeper into the subject and understand its nuances. Now, I would like to request to proceed for our next session. I would like to invite Dr. Madhu Nagpal, Head Department of Obs and Gynae, SGRD Amritsar, Dr. Kumud Gupta, former Professor and Head IGNC Shimla, Dr. Kavita Bhatti, Head Department of Obs and Gynae, CMC Ludhiana, to please come